Agenda is the roll call. Teresa, would you like to do that? Is Teresa on the call, Erin?
I didn't see her, but I had about 15 people log in at once. Let me scroll really quick. I'm not seeing her.
Okay. I don't have a list of the MAC members. Would you mind doing that for me?
Absolutely. One moment to get back where I was at. Oh, and go. I just entered some people from the waiting room. So Beth Elizabeth Parton,
Here.
Nina Eisner, and I apologize, I say her last name incorrectly all the time.
That's correct. I'm here.
Oh, yay, I got it right this time.
Yay.
Wonderful. Susan Stewart.
I'm here.
Okay. Dr. Jerry Roberts.
I'm here.
Thank you. Teresa Aldridge. Dr. Garth Bobrowski.
Here.
Dr. Steve Compton.
Here.
Dr. John Mueller. Did I pronounce that wrong? Dr. Gupta. Okay. John Dodds. Did I pronounce that correctly as well? Dr. Hannah.
Here.
Barry Martin. Kent Gilbert.
Here.
Mackenzie Wallace.
Here.
Miss Anissa Franklin sent me an email. She's not feeling well and apologized. She's not here for the first meeting. Dr. Schuster.
Here.
Brian Proctor.
Here.
Peggy Rourke. Eric Wright. Okay. It looks like we were only missing 3, I believe.
Okay, so we have a quorum.
Yes, ma'am.
Okay. Before we move on to the next item on the agenda, we have 3 new members of the MAC. And I was a couple minutes late because I was trying to pull up the names on my computer and couldn't do that in a timely fashion. So I was wondering, Erin, if you might say who the new members of the MAC are.
Absolutely. We have Kent Gilbert is new, and he is our consumer advocacy group for the disabled. Mackenzie Wallace is also new. She is our consumer advocacy group for the elderly. Miss Anise Franklin, who cannot be here today, she's not feeling well, is our also new. She is the consumer advocacy group for women. Dr. Sheila Schuster is new to the MAC and is the consumer advocacy group for minorities. And then we had Brian Proctor, Peggy Rourke, and Eric Wright were all reassigned back to the MAC again.
Thank you very much. And welcome to all our new members. Okay, so next up is approval of minutes. Would somebody like to make a motion?
I'll make that motion.
Thank you, Nina.
Second.
Thank you, Garth. Okay, any discussion? All say aye.
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 Any opposed? Thank you. And we'll move on now to old business. First up on the agenda is, will Medicaid amend regulations to reimburse by professional midwives? And I would like to add to this that we just received a letter from the American College of Obstetrics and Gynecology in support of Medicaid reimbursement for CPMs. So where are we with that?
Hi, this is Lisa Lee, Commissioner for the Department for Medicaid Services. We have Dr. Parton. We did receive a copy of that letter. Thank you for forwarding it. We do continue to look at all information that is sent our way regarding this issue, but we are not going to change our reimbursement at this time. We do have some concerns. The first one being that, the ACOG guidelines requires midwives who do home births. They're supposed to have someone with them trained in neonatal resuscitation and all the equipment needed for resuscitation of the baby. So while we're not considering it at this time, we're not completely taking it off of the table. We're going to continue to do some research, but we're not going to update our regulations at this time.
Next up is to amend the regulation for rural health clinics to extend the time to 3 days for providers to sign Medicaid participants.
And this is an amendment that we have made. That regulation has been filed. I don't know exactly. We filed the regulation on April the 26th, so that it should be on the DMS and LRC website. So that regulation has been amended and already filed.
Thank you. You can take that off the agenda now. Thank you. And then, yes,
Can I ask a question about that real quick?
absolutely.
I was just curious, what happens right now if we don't sign the chart in a timely fashion by the end of the day or within 3 days?
The commissioner has spoken to this before. Commissioner, would you like to speak to that again?
Yeah, I'm sorry, Dr. Gupta. I didn't hear the question. Could you?
I was
you wanna-
just curious as to what happens as it currently stands if we do not sign the chart on the day the services are provided by the end of the day.
I think I may, Veronica, are you on the call? And could you address that? If what happens if the doctor does not, or if a physician does not sign the chart at the end of the day, what happens right now? I believe that it could be subject to audit is my first response. And in the event of an audit, there may potentially be some recoupment, but I may have to ask Senior Deputy Commissioner Veronica Judy Cecil to weigh in on that.
Thank you. This is Veronica Cecil, Deputy Commissioner. And Dr. Gupta, we had already indicated that we're not enforcing this provision as long as it's within the 3 days is the standard that we were going to hold all providers to. So we are not enforcing the same day requirement during this period of time because we had acknowledged that we wanted to align all of the provider types. And so if a provider's getting recouped for that, or if they're identifying that in an audit as a violation, just we need to be made aware of that because we made it very clear that we were not going to enforce that.
What you need.
Okay, but just so I know that even with the new change that within, if we don't sign it within 3
Yes.
days or whatever, we could be at risk for an audit or recoupment of payment.
That's
That-
correct. So it's a condition of payment. So when we're auditing, you have to be in compliance with all of the requirements that are necessary for us to determine that it meets the regulatory guidelines. So it could potentially be a finding and a violation, which would result in a recoupment.
Okay, thank you.
Yeah.
Recording in progress.
Everybody, if I could make the request, if you're not currently speaking, to please mute. We're getting a lot of feedback and it's hard for the court reporter to transcribe when there's a lot of background noise.
Okay, next up is discussion about continuing the Zoom MAC meetings. So what is the pleasure of the MAC as far as meeting in person, moving forward, or continuing with Zoom meetings?
This is Dr. Bobrowski. Just my 2 cents. It's I guess since I've been on the MAC for almost 2 years, I got on when COVID started, so I'm used to the Zoom meetings, and it is awful handy to just do the Zoom meetings, or if we change it, you might do a hybrid type meeting, but I'm in another time zone from Frankfurt, and it almost is a whole day event or 3/4 day event to make that trip to Frankfurt. So my 2 cents is I kind of just like the Zoom, but I sure would like to meet you all in person so we could talk. But it's just a time factor for me.
I agree with Dr. Bobrowski. I mean, it is so convenient to have these meetings by Zoom. You know, decreasing the commute, decreasing our time away from clinic. But at the same time, it would be nice maybe at least once a year to meet in person. That's what we've decided for our TAC meeting, to try to meet at least, you know, once this year in person, because there is something about doing that, about making those relationships in person.
This is Nina. I agree with both of my colleagues. Zoom, I came on when Dr. Bobrowski did, and so have never experienced anything but Zoom with the MAC. But I recognize that we have had full participation every meeting, and I don't know what it was like when we were in person. I would also like to have at least once a year in person, just to be able to really meet my colleagues in person. And but a hybrid would be great for me too. Did it make a difference on participation, going Zoom versus in person?
We had, it was kind of a mixed bag. Times we had participation, but it was similar to what we're having now with the Zoom. A few years ago, we didn't have all the seats filled on the MAC. And so if 2 or 3 people were missing, we didn't have a quorum.
I see.
And that made it difficult. But I like the idea of having at least one meeting in person, because I think that there is merit in the collegiality that develops when you meet in person. I kind of miss seeing everybody and seeing everybody's nonverbal communication during the meeting, how people are thinking. And I think that's really helpful. And it's kind of helpful to know people. But by the same token, I'm in a different time zone. And in order to get to the meetings, I have to get up about 4 o'clock in the morning. And that makes a very long day. And it is a full day. You know, by the time I get home, I can't go to the clinic because I'm not getting home until 3 or 4 in the afternoon. And so, you know, it is a whole day kind of thing. So,
Beth, if I might just interject, this is Sheila Schuster. I agree with my colleagues, certainly, that at least one time in person. I do think that having the MAC meetings on Zoom makes them more accessible to non-MAC people. And as a consumer rep on the MAC, I think that transparency and openness and having people be able to, there's a lot of valuable information that's shared from DMS and from the tax, and the presentations by the MCOs are just more accessible, I think, for consumers. So I'd like to maintain at least some portion of it on Zoom, you know, for the bulk of the meetings would be my recommendation. Thank you.
okay, so
Do we have the tech capabilities to run a hybrid meeting right now? This is more directed at Aaron or DMS staff, but
So for some of our small, I'm sorry, Veronica, were you speaking?
Yeah, let me address that, Aaron. So keep in mind, if we have a hybrid or an in-person, the MAC is a very large body. So we would have to have a location that could accommodate all of the members plus an audience, you know, plus the public. And then to do it hybrid, that does add to, I think, the struggle to make sure we find a location that can accommodate both of those. I don't think it's out of the realm of possibility, and certainly We started to look at several options. LRC has a couple of Legislative Research Commission has a couple of meeting rooms, but we're dependent on them for both availability, and we would have to utilize their staff for the technology access. Our public health conference rooms, I think, would be big enough. I think they're still updating their technology to make it more virtual friendly. So we're keeping our eyes on that as a potential location. Honestly, if we could just have enough notice where you want to drop it to a hybrid, then we could work on, if you set a date in the future, we can work on finding that location and keep you guys informed about, our efforts.
Okay.
I think continuing until the feasibility of a hybrid meeting is in place, I would vote to continue the Zoom. I would, echoing the other comments, it's nice to see you guys face to face, and those 5 or 10 minute conversations that happen in and around the meeting are some of the most valuable components of the MAC. But I certainly, kind of a nod to Sheila, I think maintaining the virtual availability certainly helpful for both MAC and non-MAC members. I would love to see people in Frankfurt as quickly as possible when the technology allows.
I would agree with Jerry as well. And then another tap with Sheila as well. 128 participants in the meeting today. I mean, the last meeting I was at in person, I think, we weren't near that number. So it is nice to see the number of participants increasing and being, this information being available.
Okay. Thank you, and everybody. Does anybody else have a comment they'd like to make? Okay, so having said all that, what about if we look at maybe having an annual in-person meeting in September? And depending on the feasibility of the hybrid technology being available, that would give us a date when the weather is good, and it's in the future, a couple meetings, so we could know by the July meeting if a September meeting in person is possible. What is that? Does that sound like something reasonable, Veronica?
Most definitely. Yes. I think that gives us enough time. We can start with LRC and see if they have availability in September. Like I said, there are a couple of other options that we can look at, but that gives us enough time, I believe, for us to work that out.
Okay, so I'll leave this on the agenda for next meeting, and we will tentatively be looking at a September in-person meeting if the technology is there to do it, and the space too. Okay, next is just a reminder, at the July meeting, we'll have an update on missed and canceled appointments. How's reporting going? Is there any consensus or common thread as to why patients are not showing up for appointments? So that's just a reminder that we're going to do that in July. And then last time we talked about reasons for denials, and we were going to get the top 10 denial codes. Commissioner, are you going to do that, or somebody else?
I think the MCOs are going to be presenting on that in their reports today. So we'll be looking at that by MCO, but we could also get that in the aggregate and present that at the next meeting if you would like.
Okay, thank you. They're probably, since we're going to be hearing from all the MCOs, it'd probably be sufficient
Okay.
to hear it from them. Okay, and then the next question is telehealth. at least from my perspective, some of our patients are requesting to be able to use FaceTime. They can't figure out the other platforms and how to get the apps on their phones. So I was wondering what the status was as far as being able to use some of those other platforms.
So we have filed our regulation, that expands the coverage of telehealth services so long as the providers are operating within their scope and professional standards. We are waiting from federal guidance related to which platforms will be considered going forward. We're waiting on the federal rules or federal CMS to let us know what they're going to do at the federal level so that we can mimic that at the state. But to date, we have not heard anything about FaceTime or Zoom yet.
Okay, so can those platforms be used right now or no?
Since we're still in the public health emergency, it has not been, the public health emergency has not been declared over, but I believe that those platforms are appropriate during the public health emergency. It's after the public health emergency ends that we'll have to rethink those if we don't have something in some more guidance from CMS.
Okay, so for now it's okay.
Yes.
Okay.
Beth, may I ask a question about telehealth since we're on that topic? This is Sheila Schuster.
Yes.
Commissioner, I've been trying to communicate with some of your folks. There is a rumor out there among providers and consumers that audio only is not being offered unless you have failed with a video approach on telehealth, which presents a problem for our folks who have English as a second language, or where we need an interpreter to be present. And I just wonder, is that something that, have you all made any changes, I guess, in terms of reimbursement on audio only versus the video approach?
I'd have to go back and re-review the regulation. But again, during the public health emergency, anything that we had in place would still be standing. So if you could get some good examples to me, have someone reach out to me with a specific example, would be more than happy to look into that and find out what's going on to kind of dispel some of those rumors.
Thank you. I will definitely do that because I've heard that from several different communities, and we'll get that to you. Thank you very much.
Mm-hmm.
Okay, and next up was an update on reimbursement for multiple visits on the same day.
And I don't think that we have an update on this topic yet. We're still
Recording in
continuing to look at that. We do not have an update at this time.
Okay, so next meeting. Okay, and then next up, updates from Commissioner.
And hello, and thank you. I'd like to welcome the new members to the MAC. Very important work we do here, as you can see from some of the topics we've already discussed. This very important body of individuals has a lot of input and recommendations into the Medicaid program that actually has an impact, a direct impact on the 1.6 million members that we serve. And very important work, so welcome. One really good piece of good news, I think, I'm not sure if y'all saw a press release yesterday. Lieutenant Governor Jacqueline Coleman was on a press call with CMS in which they announced that Kentucky State Plan amendments to cover postpartum up to 12 months has passed. So we now will be allowed to cover postpartum individuals will be allowed to cover them for 12 months after the delivery of their baby, which is fantastic news for the women who are enrolled not only in Medicaid, but also in CHIP. As you know, we also expanded our eligibility in the CHIP program to cover pregnant women up to 200% of the federal poverty level. So both groups of those women will be allowed to have 12 months postpartum coverage. So we're very proud of that initiative. That policy change we think is going to go a long way to helping mothers after they have their babies and to focus on their healthcare needs as well as their children. So it's a really good policy change there, and just want to give a big shout out to Lee Geis and her team for interpreting all the federal regulations and putting those into play for Erin Bickers, who has, you all see her here on the MAC, but she is also our state plan coordinator. So for Erin, for submitting that SPA and working with CMS to make sure we got it approved. And just for your information, also, I think we submitted that SPA in March of this year. The effective date is April. It was April 1 of this year, 2022. So it was a very well put together SPA. We worked with CMS as we went forward and got that approved in just about record time. So, and then Jonathan Scott, give a big shout out to him for making those changes in our regulations. But we're very happy about this change. We think it's a positive step for mothers. No mother should lose their health insurance, within 60 days after they deliver a baby, because their health is so important. So again, wonderful news. The other thing we'd like to talk about a little bit is our basic health plan. We had plans we were developing a basic health plan. For those of you who may need just a quick update or just overview of what a basic health plan is. A basic health plan is a program very similar to qualified health plans that are offered on the exchange, except the basic health plan would cover individuals from 138 to 200% of the federal poverty level who do not qualify for Medicaid. It would be sort of a stepping stone between Medicaid and either a product on the exchange or private health insurance with a little bit of a lower premium. We anticipated that about 70,000 individuals would qualify for the basic health plan here in Kentucky. And we had an anticipated start date of January 1st, 2023. But we started listening to some of our stakeholders. There was a lot of concern that the carriers would not be able to build out a robust provider network, for example, among a few other concerns. So we have decided to push that start date of the basic health plan out to January 1st of 2024. So if you would like, more information on that at the next meeting, just let me know and we could give some updates. But basically, we were pushing out the basic health plan implementation date from January 1st, 2023 to January 1st of 2024. Another topic that we've been working on is the unwinding. Okay, Kent, I see a hand pop up there. I'm sorry.
Sorry to interrupt. I'm fussing with buttons. I had a question about the rollout. Are we clear that the people are developing those robust networks?
We're going to continue to working forward. I think we need to have a little bit more conversations and a little bit more communication with our providers to make sure that they understand, what the basic health plan is, how it would impact them. And some of our carriers have been reaching out to providers, but we do believe that by January 1st of 2024, there should be a robust network for the basic health plan.
Thank you.
Are there any other questions on the basic health plan before I move forward?
Commissioner, I would like to have more information on it at a next meeting.
Okay.
Good.
Yes, I'll plan to have maybe a little presentation
Thank
related
you.
to the basic health plan to give everyone a little bit more information. So any other questions, Dr. Schuster?
Yes, Commissioner, I guess I was seeing the basic health plan as kind of the safety net to catch people as they get unwound from Medicaid.
Yes.
I know that unwinding is going to start as soon as the federal emergency period ends, right? Which could be in July. So what's going to happen to those people as they get unwound from Medicaid?
So we're exploring a couple of different options. We're talking to CMS. Originally, CMS told us that we could file an 1115 when we thought we would begin our basic health plan January 1st of 2024. We knew that there would be some people who just a few months would need that extra coverage until they could enroll in a basic health plan. So we're exploring options. One option is to maybe look at that 1115 again to see if we could keep those individuals enrolled in Medicaid somehow. The other option is to kind of make sure that we provide really good communication to those individuals who would lose Medicaid and give them the options of the qualified health plan on Connect. So we're just exploring all options there. Again, we are not sure when the public health emergency will end. There were rumors that we would be notified in May. So we haven't been notified. We will have 60 days to start all of our unwinding activities. Once we receive notification from CMS that the public health emergency will be ending. And as we talk about unwinding, it's a really good segue into the next topic. We have been doing some social media and just putting some information out, just basically telling individuals who are enrolled in Medicaid and CHIP that we need an updated information from them, particularly for their address, so that we can contact them. You know, there are two groups of individuals we're worried about. Those are individuals who have been enrolled in Medicaid for the first time and have never had to go through a recertification process, and those individuals who may have moved and may not receive their information. So unwinding, the way it's going to impact our members, you know that we look at all other sources to verify information so that our members do not have to take action if we can verify their income status and family status, that sort of thing that determines their eligibility. If we can verify that information through other sources, then those individuals don't have to take action. So what we are planning on doing is we have a notice developed, and I'd like to thank some of the individuals on this meeting here. I know Emily Beauregard, Rich Sackle were very instrumental in reviewing those notices to make sure that we captured enough information. So our plan is to do some very targeted outreach and notification. Once we start unwinding, we want to notify those individuals who are at risk of losing eligibility sooner. So let's just say, for example, if the public health emergency ended in August, we'd want to start notifying those people or those members who would potentially lose eligibility in September, and do targeted outreach to them through our managed care organizations, because our managed care organizations do have more up-to-date address information and they are in contact with their members. So we want to do that very targeted, staggered mailing to those individuals so that they don't get a letter, for example, in September, if they don't have to renew their eligibility for, until the next year, for 6 or 7 months down the road. We don't want them to forget. So we're doing a couple of things right now, just reminding individuals to update their contact information. We are receiving about, I think the last time I looked, about 200 calls a week with individuals updating information, their address information. So that's a good thing that we have their contact information. We'll be able to locate them when they need to do a recertification. So we are focusing on all of our unwinding activities. We don't believe that there's going to be a really big impact on the provider community. There are a couple of provider groups that will definitely have to we'll have to reach out to. For example, hospitals and long-term care facilities have some special reimbursement criteria specifically related to COVID diagnosis. So we'll have to do some targeted outreach to those providers. But our main focus is on our members, because our overarching goal is definitely to keep everyone enrolled in Medicaid. We don't want to lose any of our members. We know that it's going to be a little bit of a confusing time for them. So that's what we are doing, is definitely having a huge member focus on our unwinding. And I think I'll stop there and ask if there are any questions.
Commissioner, I wonder if you're going to give an update in July on the basic health plan, if you could also just keep us apprised about the unwinding process, because it feels like that's going to be a huge kind of public education directed at those members.
Yeah, and one thing we don't want to do is to instill fear in individuals, and right. The information that we've been out, I'm not sure if you all have seen some of the cabinet's Twitter feeds related to just updating your information. What we're trying to do is just give a general message about, hey, we really want to be able to contact you if we need to, but we don't want any individual to feel that they're going to lose their eligibility. I know some states have been doing a lot of outreach and letter campaigns, and they have, for example, a couple of states have gotten specially colored envelopes to mail out to all of their Medicaid members, and it's created a lot of confusion and a lot of unnecessary phone calls to their eligibility staff. And that's another thing we don't want to do, is overload our eligibility staff right now. So again, that's why we're focusing on that very targeted, specific outreach and notification of our members.
Commissioner, how will the unwinding impact the 1915C waivers when the public emergency ends?
So the 1915C waivers are a little bit different. We do have, an Appendix K that has some special criteria outlined in it, but the 1915C waivers and that Appendix K will have a 6-month unwinding period. So a little bit longer time to plan out the changes that may impact some of our 1915C waiver participants.
Thank you.
I think that's all the updates that I have. I am going to turn my camera off. I will be here listening, but just so you know, I do have another meeting later this afternoon or immediately, like right in between this meeting. So I will drop, but I'll be listening for as long as I can. And thank you all very much for all the hard work you're doing. I appreciate all of you.
Thank you, Commissioner. And we appreciate you. We appreciate your willingness to work with us and to serve the public. So thank you. Okay, moving along, we'll go to the TAC reports and recommendations. And I would like to ask this time if the TACs will be very brief. Just give your recommendations, and if you have to give any supporting information regarding the recommendations, be very brief, because we have an update on maternal infant health, which will probably take a little while. And then we have reports from the MCOs, and I know everybody will be anxious to hear all of that, and I don't want to run over on the meeting. So having said that, first up is therapy services.
Anyone on from the therapy TAC?
Okay, then primary care.
Morning, this is Mike Caldwell. I'm chair of the primary care TAC and also CEO of Mountain Comprehensive Health Corporation, FQHC, in Southeastern Kentucky. The TAC last met on May the 5th, 2022, and it was a declared quorum meeting. Most of the things we've did has already been covered. I will not repeat and cover those. Our next meeting is scheduled for July the 7th, 2022 at 10 a.m. We did have a recommendation. It is, and I'll read that now, dental recommendation approved by primary care TAC May 5th, 2022. First, to request MAC support for a recommendation from the Medicaid primary care TAC to the Cabinet for Health and Family Services and Office of Health Policy for a state policy review of the current dental workforce shortages in Kentucky, including the use of dental auxiliaries to expand health workforce capacities. 2, the Medicaid primary care TAC further recommends to the MAC this state dental policy review should include A, current dental enrollment levels, DMD and dental specialty programs, in parentheses, in state-funded dental colleges, in state and out-of-state dental graduate retention levels, and dental scholarships, dental loan, and loan forgiveness options for Kentucky dental graduates. B, the equity of current dental fee reimbursements provided by the state Medicaid program and its MCO contractors, in parentheses, with hospitals, physicians, behavioral health, and other Medicaid providers, in parentheses. C, policies and programs that support local care coordination and integration of dental prevention and treatment services into hospitals, public health departments, school health clinics, FQHCs, and rural health clinics. That is a recommendation and is in response to the crisis that we currently are experiencing in Kentucky concerning the lack of dentists and dental care for our citizens. Thank you.
Thank you, Mike. I have a follow-up question on that. Are dental services included in FQHCs as one of the groups that can be reimbursed in those clinics?
Yes, we do have dental services. I don't believe that all FQHCs offer that, but I think that most, if not all, certainly do.
Okay, thank you. Next up is physician services.
This is
Dr. Gupta, I couldn't hear you. I'm sorry.
Can you hear me?
Barely.
We do not have any recommendations.
Okay, thank you. Pharmacy.
Okay, this is Kathy Hanna. I'm going to report for Ron Poole. He wasn't able to be here today. The pharmacy tech did meet on April 20th. They did have several recommendations. The first one was on their OTC list for skin protectant categories. They didn't find any examples there, and so they're finding some challenges, meeting that need. So a motion passed for DMS and Mid-Impact, along with the P&T committee, to review the OTC list for skin protectants, for additional products to be added to the Medicaid covered formulary. They also recommended additions to in other OTC categories. And let's see here, the motion passed for DMS to look and Mid-Impact, along with the P&T committee, to add additional OTC products to the Medicaid formulary as well. A list includes fexofenadine, Desitin, zinc oxide, melatonin gummies, Novaferum, and that was primarily because of the bitter taste of some of these products, especially for children. Various dosage forms for omega-3 fatty acids for children. L-glutathione. Many of these are for autism. Various salt forms of magnesium for autism. Taurine for autism. L-theanine for autism and anxiety. And various salt forms of zinc, chamomile, various multivitamins for adults and children, curcumin, various dosage forms of diverse probiotics for autism, eczema, diarrhea, and gut health, and resveratrol, also for autism and blood vessel health. They had some comments from pediatric providers saying that there was not adequate coverage for eczema on the formulary. And they said that this particular provider said the CeraVe is covered and listed as being covered, but doesn't seem to be able to process these claims. So a motion was passed for the DMS and Medicaid and P&T committee to look at, the eczema class and to review those products. They did list, and in the interest of time, I won't list all of them, but there's several for acne, healing, moisturizing, and different formulations of the CeraVe product. Of note, where there wasn't really a motion or anything done, but there was some discussion about having continued issues with local providers for the PA process for opioids and benzos. And they asked that, could there be some additional resources sent out to providers? I did hear that the Department of Medicaid Services did send out some resources, but they're still having some issues in that area for facilitating prior authorization approvals. There's a continuing discussion of the Suboxone reimbursement in 23 days, but there has been some movement in that area, I believe. So they continue to want to watch that. I do want to thank the Department of Medicaid Services for their assistance in resolving this issue, as well as, personally, the willingness to explore different alternatives for the TPL requirement to reverse and bill Medicaid claims. Okay. And that is it. So I tried to run through that quickly. Thank you.
Thank you very much. Okay, next up is persons returning to society from incarceration.
Good morning. This is Steve Shannon, and this is that report. We have no recommendations. We didn't meet on May 12th. We had a quorum, but we have no recommendations at this point. Thank you.
Thanks, Steve. Optometry?
This is Steve Compton. We met on the May the 5th, and we have no recommendations.
Thank you. Nursing?
I
Okay.
think Lisa's here. I don't know if she was going to review April's meeting by the nursing TAC. Lisa, are you there?
I am here. I'm very sorry. I'm apologizing. I couldn't get my mute button to work. Yes, we had no new recommendations from our TAC meeting in April. However, there was follow-up from Dee Polito that this team requested. If you are wanting to hear that now.
Is it a formal recommendation?
It was just follow-up to our
It's
previous
follow-up from
recommendation.
the last meeting where there was a recommendation made, and there were questions from Ms. Polito, for Dr. Polito.
Okay, if it can be very brief.
Yes, ma'am. Dee, you got the floor, ma'am.
Okay, so I will just applaud Medicaid for their expanded postpartum coverage that was approved in record time for that important maternal health coverage. But I really feel that it's curious that an entire population of women in Kentucky get no coverage for their prenatal care services by a licensed CPM, and that there's continued concern by Medicaid about the requirement for neonatal resuscitation when that's a requirement for licensure. So I would just like to open it up for any further questions or discussion about that, and that we really continue to have the same discussion about CPM reimbursement at each of our nursing TAC meetings so far.
Okay. Thank you. And that's an important point and well noted. And so we'll continue to encourage DMS to reimburse the CPMs. Thanks, Dee.
Thanks, Dr. Parton.
Okay, next up is hospital.
I do know Russ is not on, and I believe that he sent a document saying there were no recommendations.
Okay, thanks, Nina.
Mhm.
Nursing home. Dental.
There, had to hit trouble hitting that mute button again. Sorry. Yes, I do have a motion. Just a brief background on it. There's two main reasons that a lot of dentists are limiting their Medicaid services. One is the poor reimbursements. Dental has not had a fee increase since 2002. Would you go to work today and get your paycheck from 2002? But anyway, the second one is failed appointments. And I know we've talked about that today, but there was a letter sent to DMS from another dentist that one day she had 10 new patients. None of them showed up. None of them called. That happened to me a while back. Had 12 new patients on a Wednesday morning. 8 of them did not show up. And I mean, you just can't keep running your business with that kind of a failure rate. But the motion from our dental TAC at our last meeting was because of the increasing fees from our labs, our supplies are just going nuts out here. But the dental TAC recommends a 50% increase in the reimbursements across the board. And that'll be my report unless somebody has a question.
I have a question. So the 50% increase across the board is still not going to address the no-show issue. Is there any way to get any kind of reimbursement when a patient no-shows or same-day cancels?
One of the MCOs did give a $3 if you filed it, but you know, by the time you pay staff to file all this, it's the same thing. I know we've been trying to report the folks that fail their appointments, but again, that is just taking up so much staff time that it's just not worth even reporting the failed appointments. And I think that was addressed maybe in the letter that DMS received. I didn't receive it, but the doctor mentioned that this is it's just not physically possible, time consuming. But the problem with the failed appointments is that it's a federal situation where it's just almost hands off. We can't do anything. The only option we've got is to just dismiss the patient, and we have dismissed some, or we have limited. I mean, we had one the other day, a young boy up 30 years old. I mean, he's already missed 11 appointments. Now, how much more chances do I give him? He's 11 appointments just at my office. You know, we try to see these folks, but I think I like use the word. I think he has used up his coupons at our office. It's time for him to move on, and you hate to do that, but it's just a reality of it. You just can't keep reserving an hour, 2 hours of treatment time, you know, for doing all these fill-ins and extractions, and they just don't show up 11 times. So the problem is that it would have to come with failed appointments from the federal part of it. But I have mentioned before at some of our other meetings that, well, maybe Kentucky needs to be the national leader and come up with a policy on handling these failed appointments. Maybe we need to step it up, you know, and devise a policy and then present that to the feds, or just do it in Kentucky. You know, I know we got to go over the rules, but something's got to be done.
I think this would be good to bring up in July when we're talking about the missed and canceled appointments. I think that would be a good topic to add to that, because I think that is universal for all providers who are caring for Medicaid patients. And we want to take good care of those people, and they need care, you know, that they are among some of our sickest people. So maybe we can add that. I don't know if the commissioner is still on, but Aaron, what can we add that to that item about the missed appointments?
Yes, we can do that.
Oh, sorry, Commissioner.
Thank you.
We're both still here. Yes, thank you.
Okay. And I skipped home health. So can we go back to home health? TAC.
Yes, thank you so much, Dr. Parton. This is Evan Reinhardt with the Home Health Technical Advisory Committee. The Home Health TAC met on April 19th and has the two following recommendations. We're experiencing similar issues with supplies, so we recommend that the cabinet increase reimbursement for supplies. And we also recommend that the cabinet should increase reimbursement for home health. We're To our knowledge, home health reimbursement hasn't been increased for the better part of 20 years. So we also recommend a 50% increase for home health services. And that is the report from the home health TAC.
Thank you. Next up, consumer rights and
I
client.
think the developmental intellectual disabilities TAC was not included in the list.
We are on the list. We haven't been called up yet. This is Rick Chrisman.
Yeah. You know why? It's because on the agenda, it's the tags are separated on pages, and I missed that.
Oh, okay. I missed that as well. Thank you.
My apologies. I tried to get them all on one page and it squished everything.
It's okay. All right. So, okay. Did we just hear from consumer rights and client needs?
No, you've not heard from them yet.
No, but I'm prepared to share my report. Good
Okay.
morning, everyone. Emily Beauregard, Director of Kentucky Voices for Health. And the Consumer TAC met on April 19th. We had a quorum. I will keep this brief. We had 2 recommendations for the MAC's consideration. The first is that Medicaid DMS make certified professional midwives eligible Medicaid providers, eligible and billable, and would just echo DePolito's comments about licensure. Really having already addressed the issue that was raised earlier and looking forward to, what opportunities would exist to just move this forward. The second recommendation is that DMS distribute the brochure on emergency time-limited Medicaid, which was created by one of our consumer TAC members, actually, Miranda Brown with Kentucky Equal Justice Center, who works with many immigrant clients. This brochure was created and approved by DMS about a year ago, and we are asking that DMS distribute the brochure to providers and connectors and make it publicly accessible on the website. And then our next meeting will be on June 21st at 1:30 p.m. Eastern Time. We will be meeting on Zoom remotely. At that time, we'll be discussing the possibility of hybrid meetings in the future.
Okay, thanks, Emily. Okay, now we will go back to intellectual and developmental disabilities.
Thank you. I'm Rick Chrisman. I am the chair of that TAC, and we met on May 17th, and we have no recommendations.
Okay, thank you. Next, children's health.
My apologies. I was looking for my mute button. They did meet and they do not have a representative here today. All of their TAC members were unavailable.
Okay, thank you.
You're welcome.
And last but not least, behavioral health.
I'll make this my shortest report ever. I submitted a written report for the MAC members. We met on May 12th and we had a quorum. And we do not have any recommendations, although we got very belatedly a response from DMS to our recommendation about reminding providers to enter data in the failed appointment data collection. And their recommendation, which I will pass along, is that the MAC make this maybe a quarterly agenda item so that we keep tabs on what is being reported in that failed appointment. So it sounds like we're going to be talking about that in July as well, and we appreciate that. We are going to be meeting again on July 14th, and we are offering an in-person hybrid, thanks to Aaron Vickers, for anyone who wants to go in person to the CHR building, but we will probably keep most of our members attending on Zoom. And that's my report. Thank you.
Okay, thank you very much. Okay, so next up is the update on maternal infant health. And I know I've been looking forward to this because these reports have been very informative. So whoever's is giving that report, you're on right now.
This is Dr. Terrio. Aaron, I have a few slides if I could share my screen. I just wanted to give you guys a small update.
You should now be a co-host, Dr. Terrio.
Thank you. Can you guys see my slides?
Yes.
Wonderful. I just wanted to give you an update about what we've been doing recently and share some data with you. I don't want to repeat the same things, but I did want to kind of build on what we discussed last time. And we've talked a lot about maternal mortality, so I wanted to bring up severe maternal morbidity, which I kind of think of as near misses. So it's not a mortality, but it was close. And so this is a group of women that are at increased risk for death in that year after the birth, assuming they survive the birth, and deserve some additional attention and care during that time period. So we're going to focus on the postpartum care and postpartum time period. And when we think of maternal health, really, I kind of think of it as three separate times. So you have the time when the mom is pregnant, the labor and delivery time, that short period of time, and then the up to 12 months postpartum time. And there's different things we can do to help improve maternal health in all of those time periods. So when you're still pregnant, early prenatal care, screenings. If you screen positive for something, you can go ahead and refer for services, doula services, which are becoming more common in our state, and for our Medicaid folks. Screening for intimate partner violence and SUD, which is transportation, childcare, basic needs and necessities. Screening for SUD and depression. And then, of course, if you are deemed high risk, locking the mom into some services, more care coordination, things like that can help her get what she needs. Labor and delivery, we have our new Kentucky Perinatal Quality Collaborative, which is doing some great things. They're starting within the L&D communities, trying to address hemorrhages, addressing different things like that, plan of safe care. So that's a great partner for us. And I think we're going to do some great things moving forward with them. And then postpartum. So finally, you guys heard we got the coverage approved up to 12 months. But that's, what are we going to do with that time period? We have to use it appropriately. We need to, screen again for depression, SUD, social determinants, and help connect to services. We need to take care of our moms that have chronic diseases already. And that's part of the serious maternal morbidity issues. So, once these issues are identified, that's not the end. You need to keep taking care of the moms, and then all that other stuff that goes along with postpartum, like family planning and family spacing. So when you look at the CDC, and we talked about this before, our maternal deaths, about a third happen when the mom's pregnant, a third happen after in that postpartum period, and a third happen around delivery. And so again, different causes usually in these different time periods. And so you have to think about different ways to address the causes. This is Kentucky data, and this just shows about 80% of our maternal deaths are preventable. Again, so we can actually do something to improve this. Also, our maternal deaths have a big disparity. The rate of maternal death for Black moms is about 42 per 100,000 live births. This is in Kentucky. For white moms, it's 17 per 100,000 live births. Big difference there. And we have to make sure we're aware of this and we can address it. So when we're looking at those near misses, the severe maternal morbidity, it's really a range of serious pregnancy complications that can affect the mom, certainly short term, but long term after the pregnancy. And again, most research and prevention efforts is really focused on that hospitalization, that delivery hospitalization. But you're still at risk if you have one of these morbidities after you're discharged, and that's into the postpartum period. And so you can't just take a deep breath and say, oh, I'm so glad that's over. You have to continue helping the moms and following the moms in that postpartum period. So the CDC has come up with a list of 21 severe maternal morbidities, and you can look at them here. It could be as simple as a blood transfusion during the delivery. A lot of these other things are scary, like an acute heart attack or heart failure, acute renal failure, lung problems, strokes. So these are things that can happen that obviously are severe maternal morbidity. Again, looking at health disparities and racial disparities, Black moms are about 1.7 times more likely than white moms to have a severe morbidity. And so again, we have some issues surrounding race disparities that we have to look at in our state. This is some information from the CDC, and it's looking at about a 20-year time period, and it's looking at that list of the severe maternal morbidities. It has gone up significantly during this time. So if you look at overall the rate of some severe morbidities, it's gone up about 200% in these 20 years. And this is the most recent. I know you're thinking, why is it 2014? Well, this is the most recent national data I could find on this. So overall, up 200% of moms that are experiencing these severe morbidities. One of them is a blood transfusion. And so let's remove that and see how much it's moving up. Well, if you exclude the blood transfusions, severe morbidity rate is still about 20% higher, in this 20-year time period. So it is still going up quite rapidly. So why is this happening? And actually people don't know. People are thinking, well, maybe it's because we have more older moms having babies, but that's actually a really small number. It's because we have more chronic diseases heading into the pregnancy, but that hasn't panned out either. So it's probably a multifactorial thing. If you look at some Kentucky data, and we pulled this information about a year ago and looked at 3 years of data, what you have is breaking it out. And of course, these are Medicaid births. So if you look at 2018, you have about 26,000 Medicaid births in 2018. 25,000 of them did not have a severe maternal morbidity. And about 1,400 did have a severe morbidity. And then we looked at the women with the severe morbidities and who died, basically who had a mortality. And actually the moms that had a severe morbidity were 20.5 times more likely to die in that year following the birth than the moms that didn't. So that's huge. That's huge. And knowing them, and again, that could have just been, I needed a blood transfusion during the birth. So this is putting our moms at a big risk. We can identify it, it's identifiable. We need to be able to track the moms closer, to take more care of them in that postpartum period. So what do you do at that visit? Well, obviously you assess the mom's physical recovery, from the pregnancy and childbirth. You monitor very closely any moms that had a near miss or a severe morbidity, address the chronic conditions, maybe even diagnose those chronic conditions ongoing. And then you look at mental health status, you look at postpartum depression and screen for things like that. Talk about the family planning, counsel moms on nutrition, breastfeeding, other preventive health visits. And I don't know if you guys were like this, and maybe this is a overshare, but when I have 4 kids, and when I was doing, in that time of my life, I never saw another doctor. I was busy, and I went to the OB. That person was basically my primary caregiver. So if they weren't going to be taking care of, any issues that I had, such as hypertension or diabetes, then nobody was going to be taking care of it. And I don't think I'm abnormal. I think a lot of moms do that, when they're young and healthy. They don't have time to go to multiple doctors. So when we looked at our postpartum visit rate for the state, we were right around 61%. And that is going back several years. So we want to do better than that. If that visit is that important, why are only 61% of our moms getting there? So then I looked at, this is called a funnel plot. And that 61% is our average, and that's that blue line. And then the little dots on there are birthing hospitals. So that's looking at the hospitals in the state that have births. And the funnel part, that red funnel part of the graph is saying, okay, if you're falling inside that red line, that is kind of an expected variance. If you're outside of the line, you're an outlier. So you could be a good outlier, like you're doing better than the average, or you could be an outlier because you're not doing as well. And so the idea of the funnel plot is to look and who are the outliers, and then look at issues that address the outliers. And again, these are birthing hospitals. So I went through and I put little red circles around the hospitals that are birthing hospitals in the Appalachian Regional hospitals, the 5 birthing hospitals. And you can see that we do have some outliers. We have 3 outliers. 2 are very good outliers, some of the best rates in the state for moms getting postpartum care. One of the hospitals is right on the average line. One is right on the line, the underneath red line. And there's only one that is falling outside as an outlier, as needing to have some improvement. So I thought this was great. When you look at, just out of curiosity, I looked at the 2 little birthing hospitals that have the black box around them. Those are our academic medical centers. So one of them is UK and one of them is U of L. And so you can see one of them is an outlier in the kind of bad direction, and one is right on the line. So the ARH hospitals should be very happy that they are basically mostly doing better than the academic medical centers. So when we look at this a little bit more closely, these are the 5 birthing hospitals that are ARH hospitals. Looking at the postpartum visit rate in 2018 and 2019, just put the average number of births there per year, so a good number of births. And as you guys know, Eastern Kentucky has a great burden for substance use, so pulled that out as well. And you can see, for example, Hospital D, 46% of their moms have a substance use disorder. So that's a lot, but they're above the state average with getting to their postpartum visits. Everyone else is around 20% or so, which is a lot of moms that have substance use disorder. Then out of curiosity, looked at the readmission rate and the ED rate per hospital. And this was interesting as well. So the hospital with the lower postpartum visit rate had a fairly high readmission rate. The readmission rate is the green line. The hospitals with a higher postpartum visit rate had the lower readmission rate. So this is actually a very small number of patients. So I'm very curious. This is only 2 years. I want to look at more years to see if that actually holds true and starts to make a division there. So we'll have to keep looking at that. The red bars are the ED visit rates, and there's really no difference between the red bars. But I was shocked with 40 to 50% of moms, of the 26,000 moms that give birth every year, go to the ER at some point during that next year. I just thought that was a whole lot of young, healthy people going to the ER. So I don't know what that means. I don't know if that's their place of choice for care, or if they feel they don't have access to care during the time of day that they need it, or the day of the week, or what. But that just seems like a great number of people going to the ER during that time period. Then looking at the readmission rates, there are about 660 unique diagnoses for those admissions. And I pulled out the top 2 for each admission. And this is the top 10. So out of the 660 diagnoses used for the readmissions, these are the top 10. And very scary, especially Dr. Schuster, you probably already figured this out, but suicidal ideations was the top diagnosis for readmission following the birth of a child. Suicidal ideations. That shocks me. Again, another diagnosis in that top 10 is major depressive disorder. So we have a big problem with our postpartum moms requiring or needing some behavioral health or mental health care. And they don't seem to be getting it, because I feel like if they were getting it, they would not be admitted to the hospital for suicide. So it would have been addressed earlier than that. So again, a big reason to get postpartum care and have a trusted person in your corner, caregiver in your corner to help you with whatever needs that you may have. So when you're looking at those ARH hospitals, I'm very curious to see B and C were the top performers. And this is postpartum care we're talking about. So they're obviously associated with outpatient facilities like FQHC. I want to know what they're doing to have such high attendance at those visits. They're obviously doing something right. Can we learn from them and expand it to all of the other hospitals? And I really think that improving postpartum care, especially screening and identifying depression in that population, is really going to do wonders to help improve the health of our new moms. So these are some things that we really need to address as we move forward. This, I don't know if you guys have seen, and it's on the website, but I pulled it out here so it would be conveniently in the slide deck for you. This is a side-by-side from our MCOs on maternity benefits. So when you're seeing a patient in the clinic and they say, oh, I have Anthem, you can, look and see what they may be able to incentivize, get for incentives or things like that. So that's all that is. And it's actually 3 pages. So we have, the first page, the second page, and the third page. But that's really there just so you can have another way to get to it when you need it.
Dr. Terrio, I believe there's a question in the chat.
Oh, okay. I can't read it.
Oh, I'll read it to you.
Okay.
This is Kent Gilbert. So I'm curious as to if we've checked on the availability of counselors through the Medicaid and how that tracks with ED admissions through depression or suicidal ideation. What are the current caseloads? What's the availability of mental health care? And how does that track for postpartum patients?
I don't know the answer to that, but that would be really good to find out. I would worry that it's not being utilized as much as it can, even if that service is there, because moms aren't going into the doctor, so moms aren't being identified early on. I mean, and that doesn't mean all moms, but clearly we have to improve that.
It goes back to your point about screening, which I thought was very appropriate. I think, the early screening for anything is so much easier to deal with than ER visits.
Yes.
Thank you. I'm
And,
sorry.
I will tell you that there's a shortage of behavioral health providers, period, probably across the state. But the other problem, and I got into this because of Senator Julie Rocky Adams had filed, I believe it was Senate Bill 95 to do screenings for postpartum depression. And I ended up talking with a lot of OBGYNs and a lot of pediatricians and a lot of mental health people. And we decided to work on this over the interim because there are several issues. One is about screening. And I guess my bias is that I think we have to be very careful about screening in the sense that once you've screened and asked the question, you better have something to offer. And so when you ask the question, which certainly needs to happen, the shortage of behavioral health, particularly behavioral health professionals who have some expertise in this area. Not everyone is equipped to deal with mood disorders is now the generic label for postpartum depression. So I think that's a huge problem. The other thing that we got into, and Dr. Terrio, you may be interested in this, was a kind of who should be doing the screening and follow-up postpartum, because actually it's the pediatricians that see the moms much, much more frequently than the OBs. So even if they get in those first 60 days, the OBs may see that mom one time, but it's the pediatrician at the well baby checks and all of those kinds of things. And the pediatricians indicated to me that they were extremely interested in this because obviously the health of the child is dependent on the health of the mom, particularly when it's a behavioral health issue. But they have no mechanism for screening a mom. You know, the question was, do they open a chart for that mom? Is there a billing code for that pediatrician to do that kind of mom wellness check? I mean, there are just lots and lots of issues about this that I think need to be discussed, and hopefully we'll have an opportunity if we can get some focus from the legislature on this. There have been a number of bills filed in both the House and the Senate by both Ds and Rs around this issue. So I think there's a lot of interest and concern about this, but I don't know if you have any response to some of those issues.
Thank you.
as well.
Yes, thank you very much for that comment. I don't know if people know this, I'm a general pediatrician, and we have screened for postpartum depression for years in our clinic. And yes, when we started, we got a lot of pushback because people would say the mom's not my patient, you know, the baby's my patient. But just as you pointed out, that's really not true. You can't, separate them. They kind of go together. And so over time, it has become very commonplace. We screen at every checkup up to 6 months of age. The American Academy of Pediatrics actually has a policy statement that has been around for a good 15 years that says screen the mom when they come in during the first year of the baby's life, screen them for postpartum depression. When we screen, and the clinic I'm with is in Louisville, we have a list of who to refer to that we know is a good list that are able to take moms with newborns with depression, and it's a list we go to all the time. The other thing is we screen and we put that screening on the infant's chart, and Medicaid will pay for that screening. So even though it's a screen on the mom, billing it on the baby's chart is reimbursed. Now, I don't know if other people besides Medicaid does that, but we certainly do that.
Thanks. That's very, very helpful. And we'll be back in touch as we pursue this during the interim. I appreciate that very much.
Dr. Terrio, that I didn't know that, and that's very interesting, and I think helpful. The other piece of it is, though, in rural areas, we don't have pediatricians, so we probably need to be encouraging people in rural practices, rural health clinics, and the FQHCs to be doing that screening and encouraging the moms to come in after they see their OB for their 6-week checkup at least, or before.
Yes, agreed.
Because I don't think that's happening. At least in my experience, that's not happening. You know, when they deliver their babies, they go and see their OB for the checkup, and I don't see him again for a long time sometimes. So,
Right. And that's a very good point, Dr. Parton, because probably the baby is getting care. So, you know, the mom might not seek care from anybody after that 6-week visit, assuming she went to, 61% of the time they make it to that visit. But probably the baby is getting care. And so if they're going, to a family practice person, a pediatrician, wherever that baby is going is the person that should be screening for some of these things. And honestly, not just postpartum depression, that's just a more obvious thing to screen for, but screening for social determinants of health. You can screen for all of these things at the baby visit and help the family.
Yeah, I think that it would be really helpful to have some kind of educational process or something coming from DMS to providers in the rural areas to remind them about this, because I don't think it's happening.
Okay, thank you.
And then I had one other follow-up question on the screening for hepatitis C. That bill passed in 2018, and I was wondering what the impact of that is if we are catching hepatitis C cases because of that screening.
I can get the numbers on that. We are. There's a lot of increased screening going on, so I can get information on that for the next meeting.
Okay, thank you.
And if I might just ask also, we're concerned about that discrepancy between the white moms and the moms of color. I assume you mentioned Black, I assume Hispanic or brown moms are included in that count as well. So a lot of the legislation that's been proposed has to do with educational materials being posted on the cabinet website and being made available to the mom and to the family members, which I thought is really a good recommendation. At the hospital, we don't have birthing centers yet in Kentucky, so most of these births are taking place in the hospital. Do you have any idea, Dr. Terrio, if those materials are being handed out in the hospitals? Are they posted on the CHFS website?
Honestly, I do not know the answer, but again, I can find out and get back with you.
Thank you. I just think that we really need to make a concerted effort with our, there's such stigma often in the Black and brown communities around behavioral health, period. And I think there's, some resistance to that. So I think a very targeted education available in Spanish, hopefully, and maybe with pictures of brown or Black moms and babies, that kind of thing might be helpful as well. Thank you.
Thank you.
Any other questions?
I have a question. This is Dr. Gupta. That was such a great presentation, and I'm just wondering that mental health code that the pediatrician can use on the baby for the mother, is that something that could be that all pediatric subspecialists could use as well? Because a lot of us that are pediatric subspecialists will see these babies many times, and of course the mom won't be going anywhere else for herself, and we see these mental health issues in our subspecialty practices as well. Is that something that we could use across the board for all pediatric subspecialties? And my second question is, if we do encounter a mother like this, how do we get a hold of that great list that you have to refer them to?
I would think there's no edits limiting who can use those codes. So I would assume that anyone, when you're seeing the baby, can screen and use the code on the baby's chart for the mom. But the lists are specific to regions and locations. So we have developed the list in Louisville that we refer the moms to. You know, obviously that will be different in Lexington or Bowling Green or Hazard. And it's part of it, it depends on where you are. You know, it would be reaching out to those providers. I think when we originally did it, we reached out to some of our OBGYN colleagues and asked where they referred people, where they referred pregnant women. Then we contacted those folks to see if we can refer to them. Now, one of the, I mean, you want to make sure that they will see a pregnant woman, and that means right away. You know, you can't say, okay, I'll give you an appointment in 2 months. You know, so they, you know, it has to be someone that's going to recognize the importance of getting the mom in quickly. And so it really was, you know, making phone calls, finding out, you know, who's doing what we or asking them to do, and then keeping it up, you know, talking to the moms, you know, did you get in? What did they say? You know, did you like the person? And so then keeping that list current, moving forward.
Do you know the code offhand?
No, but I can email you.
Okay. And may I email you offline as I'm in Louisville?
Yes.
Okay. Thank you.
Thanks.
Would you share that code with all of the MAC members?
Yes, I sure will.
Thank you. Any other questions?
Dr. Terrio, you can send that to me and I can send it out to everyone in one email if you'd like.
Okay, I sure will. Thank you.
Okay, well, thank you very much. So, as always, I appreciate your updates and it's very informative. I'd like to do it again. Maybe we can do it like every 6 months and get
That
an
sounds
update.
great.
Okay. So I'll write that down.
I think Dr. Schuster had a question in the chat.
Go ahead, Sheila.
I was just asking if the PowerPoint will be made available to all of us, because I think it had some great information in it. Thank you.
Yes, ma'am. I will also send that out to the board.
Thank you.
Okay, so let's move on then to our reports from the MCOs. And we have got about 55 minutes. So each MCO about 20 minutes, a little extra time than maybe we thought we would have. So that's good. And Etna is first up.
Hi, good morning. This is Paige Mankiewicz. I am the Chief Executive Officer for Aetna Better Health of Kentucky. I ask that you please bear with me. I've been under the weather this week, and so my voice is a little bit shaky, but we will jump right in here. I'm going to share my screen. Dr. Parton, is it your preference that questions are held till the end, or do we want to take questions during? I'm fine either way.
Let's hold it to the end so that you can get
Okay.
the presentation.
Okay.
We have about 5 minutes for questions.
All right, not a problem. Let me get my screen going here. Hopefully you all are able to see that. Let me make it presentation mode. Okay, I need to switch screens. I apologize. Bear with me for just a second.
If I could ask Erin if the slides from both of these presentations can be shared after the meeting.
Absolutely. The MCOs were kind enough to send those to me ahead of time.
Great, thank you.
I apologize for the delay here. I'm having a problem getting my, there we go. Let's try this. All right, are you all able to see the full screen now?
Yes.
Okay. So again, I'm Paige Mankiewicz. I'm the CEO. Kelly Pullen, who is our Executive Director of Kentucky Sky, is on the line as well. She's actually going to drop our email addresses into the chat while we're talking here today. And I would just welcome, if there's any questions that we don't necessarily get to during this time, or if you have more individualized questions that you'd like to pose to us, please feel free to use those emails, reach out to us. We would be happy to schedule one-on-one conversations or continue the discussion that we have here today. So moving to my next slide, this is an overview of our membership as of March in 2022. We have almost 249,000 members across the state. You can see our membership breakdown by county as well as by region, and also adult versus adolescent. Of this 249,000 members, approximately 28,000 of those make up our SCI population, which Kelly will give more information about here in just a few minutes. But in essence, the high level is SCI is our program that we run for children who are in out-of-home care or in DCBS custody or in juvenile justice custody. It's a program we're very proud of, and I'm excited for the things that Kelly will be able to share with you about that. Next, we've got just an overview of some of our quality outcomes. We are rated 3.5 out of 5 in NCQA's Medicaid health plan ratings. NCQA switched in the last couple of years from doing accredited, commendable, and things like that to a star rating similar to Medicare. The overall rating score is a weighted average of all the measures, so it's not necessarily an average of the three components, or excuse me, the three composites that you see here. Looking to our plan details and the measures where we had the strongest performance, you'll see those depicted on the right here. And let's see. This is, I apologize, there was one other slide I wanted to mention on here. I think it follows. I'm so sorry. I'm just still getting over an illness, and I've got a little bit of brain fog going on. We do have value-based arrangements with many of our provider groups, especially our large PCP groups. The point of those arrangements in a lot of ways is to help drive quality performance and to achieve outcomes that are beneficial to our member first and foremost, but then also our provider partners, in addition to the outcomes that we're wanting to drive from that quality perspective. So here you can see our year-over-year trends with HEDIS outcomes. There are obviously a multitude of HEDIS outcomes that are tracked and trended. So we just focused on some of the top 5 here that we saw improvement in, as well as some that we have areas for improvement in. We do see the impact of COVID, especially in the ones where we have areas for or opportunities for improvement. I think that COVID had a dampening effect. Fewer people were seeking care, follow-up care, things like that, just due to a multitude of factors. A large one being, I think there's just, especially in the beginning, a fear from being in an office and things like that. So we have our areas of opportunity that we plan to focus on in the upcoming measurement year. We're just wrapping up HEDIS season this year. And, I hope to see some improvement in these categories. But we obviously have quality strategy that we build out, and these measures are one of our main areas of focus. Here's just some graphic depictions. I'm going to move through some things quickly and some things a little bit more slowly, just given the time that we have here today. But again, these slides will be shared. So if you have questions, please feel free to reach out and ask those. But we just kind of put in graphic form what we've shared in a high level overview. For our COVID vaccination rates, you can see here, I think that we put forth a lot of effort into achieving good COVID vaccination rates. I think that we, had hoped to perform a little bit better, just to be completely transparent and honest about it. We have offered incentives to members since the beginning of 2021, once the vaccinations were approved by the FDA. we offered $50 per dose for Moderna and Pfizer, and $100 for Johnson & Johnson. And as age categories were added to the eligibility of the vaccinations, we expanded those incentives there as well. We also offered provider incentives to our VBS
Hey man,
groups.
not much. It was on the on a
Sorry, we're getting some feedback.
Teams meeting
If
with
you
Erin.
check your
Please mute.
That I had with her when you.
Sorry about that, Paige.
That's all right. Thank you. No problem. We also offered a provider incentive to our VBS partners who assisted us in achieving vaccinations for our members. We partnered with local CBOs as well as independent pharmacies that are part of the CPESN pharmacy network. I've got some slides on that in general later in this deck, but to hold vaccine events, community events, we recognized that often local providers and local pharmacies are the ones who are the best influencers with members. And so we wanted to partner with them and let them help tell us what would incentivize or encourage a member to get vaccinated. We still have some work to do. We're continuing our incentive program. We're still open to and looking for partnership opportunities to impact our membership. We know that COVID is not something that's just going to go away, and that vaccinations remain really important. So I just, would ask this group if you have recommendations or things that you think might be effective in continuing to impact that vaccination penetration rate. We are certainly open to partnering with you on those things and providing support where we can. This is just another look at our vaccination and incentive breakdowns by region. We've also been really involved with the Kentucky Association of Health Plans activities. We have a work group of all of the MCOs that have put on a lot of events across the state. We've done things like giving away trips to Disney World and attending the fair and the festival for the Derby. And we just put on a big RAM clinic, which was a little bit tangentially related to COVID, but still incredibly important. So individually, we've done a lot. And then as a group, I think we've also done a lot. And we'd like to see more vaccinations, but we're fairly pleased with what we've done so far. Here's, again, a quick overview of the value-added benefits that we offer to our members. We've broken these down in this slide and the next slide for just general health and then social needs. So you can see by health concern, various value-added benefits that we do offer. And then we recognize that social determinants of health are hugely important in making sure that members achieve overall health and that they are able to keep appointments that they've made, that they have medication adherence, things like that. Oftentimes there are just other things going on in their lives that prevent them from being able to focus on their health. So we want to make sure that we're addressing those other areas in addition to helping them make and keep appointments and make sure that they're taking their medication correctly. I'm going to go through these pretty quickly. They'll be in the deck for you to review, but I know that the MAC asked for some specific metrics and things like that. So I want to make sure that we get to those. Okay, now I'm going to turn it over to Kelly Pullen. She is the Executive Director of SCI, and she's going to walk through some of the outcomes and the good work that we've seen take place in that program.
Thanks, Paige. So for those of you that are not familiar with the SCI program, that is the state supporting Kentucky Youth Program. We affectionately refer to it as SCI. And that really means that children that are enrolled in SCI are receiving their coverage here through Aetna. But in addition to those traditional Medicaid benefits, we really do provide a high-touch approach to care management for these members to help them reach their health outcomes. and have some robust training and system of care programming that helps the families in this program navigate the various systems that they're intersecting with here in the state and make it easier for them to get the resources that they need. Next slide page. So our purpose, just kind of summed up really briefly and in simple terms, is really to incorporate youth voice and choice in our programming, improve those long-term health outcomes for members in SCI, achieve safety and permanency, and to reduce psychotropic polypharmacy among our system-involved youth. Next slide. So SCI has multi-modal interventions here that you see at a high level on the screen. We've got a lot of cross-system collaboration with our system partners at DCBS, DJJ, Medicaid, and DBHDID, and also with our provider networks. We also have a robust trauma-informed system of care principle application and are partnering with the University of Kentucky to roll out some enhanced and intensive trauma-informed care training for our system partners, but also our provider network. We are very blessed to have significant data on these members now that they're with one MCO. We are able to share a lot of data analytics at an aggregated level, but also an individualized level for us to inform the interventions that we're putting in place for these members to improve their health outcomes. And I'll talk about a few in just a second. We also are working really diligently now that we've got a lot of data and can identify some system pain points to make some targeted investments into our continuum of care and are really focused on increasing access to evidence-based psychosocial interventions here in the state. Recently sponsored an initiative where we were able to help 200 clinicians in Kentucky get certified in EMDR. So we're really excited to pull some of this data and make those targeted investments in the system where we know there are gaps for Kentucky's children and families. As I mentioned, we do have a really high-touch approach to care management. Within that, our care teams are providing some services that look really reminiscent of what you would see in the provider system. So meeting with these families face-to-face, meeting with them every single week. Kids that are stratified into our most complex tier are receiving high-fidelity wraparounds by our care managers that are certified in that practice. And Paige, I'm still on that last slide, sorry, didn't call that out while I was speaking, but you'll see on that last slide just a couple of different other interventions, some that are really targeted at, education for these members in terms of helping them navigate the Medicaid system, also have some targeted education on psychotropic polypharmacy, on informed consent, deprescribing, so really just robust multi-modal intervention. Next slide, Paige. In terms of membership, Paige mentioned this at a high level. We've got just a little bit over 28,000 youth that we're caring for in the SCI program. You can see at the bottom of the screen the breakdown of those enrollees by their type of assistance. So the bulk of our members are kids that are adoption assistance members. So they're receiving that stipend still from the cabinet but are not actively committed to DCBS. Followed by those kids that are in out-of-home care. We've got a little over 8,000 children who are actively in foster care that we're serving. And then we also serve former foster youth up to the age of 26. And those individuals do not have to recommit to the cabinet to remain in SCI, which that population is pretty vulnerable and prone to some poor outcomes as a result of their system involvement at a younger age. So we're excited to be serving them. We have seen over the last year and a half that particular type of assistance by member breakdown has been steadily increasing. And then we also serve DJJ youth. That tends to be our lowest type of assistance breakdown in this program. Next slide. So here, and I won't read all of these, but wanted to give folks visibility into some of our overarching SCI program goals. Our team, when we went live with this program, we're very intentional about setting program goals and targets And we actually report out in a quarterly governance council our progress since we have gone live quarter over quarter, and then at the end of the year, we're reporting those yearly trends. Our team, now that we've got a year of baseline data, has been able to set those targets that we are monitoring against ourselves. So Paige, I'll let you go to the next slide and we'll run through just a couple of these as an example. This one is our weight management improvement goal. We have our performance improvement project with DMS, and here what we're seeing is we want to increase the rates of our members going to those weight assessment and counseling for nutrition and physical activity appointments. In our first year, we met our indicators on 1A and B, which is really showing that vast improvement in BMI percentile documentation and showing vast improvement in getting our members that are at risk of obesity into those appointments. Next slide, Paige. One thing that we're really passionate about, I'll be really quick here, is reducing the overprescribing of psychotropic medications for this population. We work really hard in collaboration with our wonderful partners at DCBS to achieve the success that you've seen on the screen here. We have a couple of different targets. One that's really important is that these kids go to their metabolic monitoring, which was not happening. You can see last year at Go Live, our percentage of kids that received that necessary metabolic monitoring was 5.2%. Throughout the course of the year, we now are up to 43%. So seeing a significant increase with our care coordination resources and getting kids to that necessary appointment. We've seen a 23% reduction in pharmacy costs associated with our members that are involved in this initiative. And then you can also see up top some generally successful outcomes, 28% at 90 days post these consults that we have, and 44% at 180 days post consult. Next slide, Paige. And I think this is the last one that I'll present on just due to time, but we're really focused on keeping kids in the state of Kentucky. And so here what you're looking at is our success rate in diverting out-of-state placements and returning children back into the state of Kentucky. From January of 2021 to April, we were able to divert 296 youth from going out of state, which equated to 61% of the kids that we were working on. So really working with the cabinet here, again, making some investments in this system to ensure our providers are equipped to take care of this acute population. The last slide that Pete has, I won't talk through, but just give some training updates, and please reach out and let us know if you have any questions about this.
Thanks, Kelly. I do want to be mindful of the time. I'm going to go through the remainder of the slides fairly quickly. We have provided here depictions of our provider network on in graphic form. We do provide monthly and quarterly reports to the state on our provider network as a whole, provider network adequacy, terminations, things like that. As well as access and availability. We are doing quarterly sampling and surveying of our network to make sure that we are meeting those contractual requirements and addressing any gaps that we might have, and creating a more robust network where we're able to, even if we are meeting the adequacy and the appointment availability, if there are opportunities to strengthen that, we're certainly looking for those as well. I did want to get to, because I know it was requested specifically, some claim trends. I'm going to pause here for just a moment. The audit requests that we have by month, you'll see here, you'll notice that there are some peaks and valleys month over month. And I think that the reason for this is just the team that we have that's doing data mining and looking through claims information and things like that to identify areas where we might want to take a little bit of a closer look, send out records requests, and then are pretty hands-on in working through those requests with providers directly. So they, may send out some at the beginning of a quarter and then work through those. And so that's why you will see those numbers dip down later in the month. Again, I'm happy to take any questions on that, whether it's at the end of this presentation or in an offline discussion. Our claim trends are pretty consistent year over year from 2019 through 2021. we are not completely, I think we feel pretty confident that most of our claims have run out at this point, or we're pretty close to it, but we do have a 1-year timely filing. So the 2021 data may not be entirely complete at this time. But I think what you'll see here is a lot of consistency over the number of claims that were received, relatively so, as well as, you know, how many were denied versus how many were paid on an annual basis. There are our top 10 claim denial reasons, and they are mostly driven by duplicate claims or lack of eligibility for the member. And often there are billing errors that we do try to work through our PR team with providers to get those things cleared up and make sure that those claims do get paid appropriately. The last thing I'll focus on right here is just our prior authorization trends, which was another request. And I think we provided this prior to this meeting, a much greater overview of what this looks like. But similarly, pretty consistent as far as percent of denied versus approved. It looks like approve on average more than 80% of the prior authorization requests that we receive. I do think it's important to note that prior authorization is more than just an administrative process. It's an opportunity for us to connect with providers and make sure that we understand the needs that members have, whether they be for the particular service that's being requested, or if there are social needs, if we need to engage someone in care management, assist with management of chronic conditions, things like that. So I do believe I'm at time. I'm going to pause right there, Dr. Parton, if you don't mind. And again, these slides will be posted and shared, and I welcome questions and would be happy to also engage offline. I think you're muted, Dr. Parton, if you were speaking.
Thank you. Any questions?
Beth, Sheila Schuster, not a question, but I just want to compliment the SKY program. We had Kelly and Susan Vickers present that psychotropic medication data to the BH TAC. And I would recommend that the Children's Health TAC also get that presentation. This has been an ongoing issue, and it looks to me like SKY Aetna is really doing a good job of ratcheting down those numbers of kids and making sure that they have a diagnosis and a treatment plan, not just getting a lot of meds which are not FDA approved. So I appreciate that. It's really compelling data.
Thank you.
Thanks, Dr. Schuster. And I would add, we're happy to come and present on any of our initiatives and really dive into them if any of the other TACs are interested in that. We know we're always pressed for time, but as Susan and I mentioned before, we love the access to data that we have and are really proud of the program interventions we put in place. So we would welcome any invitation to come and share about this program.
Thank you. We have received a lot of information in a very short period of time, and you have covered the questions, and I really appreciate that. What I would like to do is set aside a time at our next meeting, just a brief period of time for MAC members to digest these slides, and then if you have questions, we can ask them at the next meeting. In fact, if you have questions, you can send them to me, and then we can forward them so that both Aetna and Anthem can have those questions ahead of time and speed up the answers at our next meeting, if that would be agreeable with everybody.
Yeah, absolutely.
I want to mention really quick, I meant to mention this earlier, all the presentations that are given to the MAC, also within 2 weeks of our meeting, I try to have them up on the CHFS website for all of our new members. That's where you can always locate the presentations. I also email them out, but if for some reason it doesn't come through, they can always be found on the website, and that includes Dr. Terrio's presentation.
Thank you. Okay, so thanks for that great presentation. And if we will come back at our next meeting in July with some questions. So moving ahead then, let's go to Anthem.
All right. Well, Dr. Parton and members of the Medicaid Advisory Committee, it's such a pleasure for us to be here with you today. I'm Leon Lamoureux. I'm the Anthem Blue Cross Blue Shield Medicaid Plan President here in Kentucky. And with me here today is my Chief Medical Director, Dr. Daniel Brunner, and my Community Engagement Director, Amanda Stamper. We'd like to thank you for the opportunity to be here today. Anthem has been serving the Commonwealth for 83 years, and we began serving the Medicaid population in 2014 with the expansion made possible by the Affordable Care Act. Within this deck, its appendix, and the attachments supplied, we have answered the questions outlined in the original invite. Since we have a lot of ground to cover, I and my team will do our best to hit the highlights, draw conclusions, and guide you to specific answers within the deck or the attachments included for our submission. In 2022, Anthem has grown to become the 4th largest MCO in Kentucky with 170,815 lives. 49.1% of those lives are childless adults that are part of the Affordable Care Act expansion population. And we have a geographically and ethnically diverse population scattered all throughout the Commonwealth. The Insights dashboard that we're displaying now is something that we show to DMS each month. And from this report, you can observe in the top left, the average time it takes for Anthem to pay claims is 8.1 days. You can also see total claims paid, total spend, encounter acceptance rates, etc. In the top right, the average speed of answer for the provider community is 13 seconds and 10 seconds for our members. The box in the bottom left outlines top prescriptions by number of claims and by dollars spent. The box in the bottom right illustrates the top diagnosis by claims paid and by claims counts, just to be able to draw some distinctions. In the center of the dashboard are examples of the HEDIS quality measures comparing the 2 most recent years. And most all of the quality measures are trending well above prior year's levels. Just right of center are some key utilization statistics comparing 1 year over the most recent. And one highlight that I would like to make is the 1,970 telehealth visits per 1,000 members, which is compared to 1,500 visits per 1,000 1 year ago. Since 2021, Anthem Medicaid has been using a process that we refer to as Elevate. It is a data-driven, stakeholder-influenced, member-centered, population health and health equity planning model. Elevate underscores our commitment to elevate whole health and advancing health beyond healthcare for our consumers, their families, and our communities. Elevate is a transformative approach to healthcare that delivers integrated whole person care at the member level, while also promoting health equity and resiliency in our communities. As you can observe in the visual on the left, we initially focus on data and analysis. Through this data-driven approach, we identify health needs and disparities. We then turn our attention to seeking stakeholder feedback. Once incorporated, we begin to develop and implement multidisciplinary, fully integrated, whole person-oriented strategies. We then analyze outcomes and in an ongoing quality improvement way, adjust as needed to be able to address the issues and concerns to ensure results. When we look at our strategic process for 2022, we identified 8 major domains of focus, namely in alphabetic order, behavioral health, cancer, COVID, chronic conditions, dental, maternal and child health, health-related social needs, or otherwise known as social determinants of health, and substance use disorder. On the right-hand side of the visual, you can see the top-level performance metrics for each of these domains of focus. Examples include reduced suicide attempts, reduced overdose rates, increased childhood immunizations and prenatal care, just to name a few. The 4 examples profiled in this slide are just a few of the strategies and tactics designed to increase results in our key domains of focus. Projects like our doula pilot, hosting dental days in underserved communities, offering rural health grants and scholarships, and alignment between member and provider incentives, combined with member and provider education efforts to achieve results. As providers of quality care, you are of course key partners as we coordinate members' health and social needs and continuously seek feedback and collaborative opportunities with you so that we can continue to evolve from payer to partner. Convenient access is one of the most important things that we offer as a managed care firm. As you can see from the statistics on this slide, Anthem significantly exceeds our contractual obligations of 95% of the members with access to all key specialty types within specified time and distance requirements. In fact, for all but rare specialty types, 100% of Anthem members have access to provider within the 30 or 50-mile distance requirements. One thing I like to point out is in the column on the right that shows the average distance to at least one provider in each provider category. For instance, Anthem members have access to at least one PCP within an average of 2.46 miles. We are constantly striving to sculpt and improve our network to even further improve access to local providers. And we're encouraging telemedicine as a way to further enhance access, particularly in rural communities. In addition to the time and distance requirements for providers, MCOs are also held to a ratio standard. Anthem significantly exceeds the ratio standards. PCP ratio requirements, as outlined in the MCO contract, are one provider for every 1,500 members. And Anthem's ratios are 1:11 for family practice, 1:13 for internal medicine, 1:39 for pediatrician, and that kind of performance continues. Until 100% of our members receive the care that they need when and where they want it, our network development will continue. Each quarter, we're required to submit network adequacy reports to DMS, and here is just one example of the information that is supplied. The network adequacy reports outline access by zip code and maps to the data to demonstrate coverage or lack thereof. It's important to note that for adult PCP, for instance, which is the one example that we've demonstrated here, we have 3,400 unique providers in 2,600 locations, and 92% of which are open to new patients. 8% have closed their panels to only existing patients. All MCOs are required to monitor appointment access and availability. Unfortunately, as has been mentioned, COVID has strained providers' capacity, and that is particularly true for behavioral health prescribers. And most provider types are very close to meeting their contractual access standards. As we think about quality of care, Anthem strives to be an accountable partner to DMS in advancing quality healthcare. We collaborate with providers to meet you where you are with implementing value-based programs. As a leader in this space, we have a variety of programs to suit the different practices in our network. 66% of Anthem members have a PCP who participates in our value-based payment program. And we're collaborating with other MCOs on a quality strategy development work group specifically focused on access and cost across the whole industry. As we look at our quality, as noted in the bottom right corner of this slide, Anthem is tied for first place with 3.5 stars. It's also interesting to note that for the most recent measurement year, Anthem Medicaid achieved 4.5 stars in our CAP survey. Since there are far too many data points to review in this format, let me share with you Anthem's best performing quality domain is the maternal and child health domain. For some of the specifics details, I will direct your attention to the slides 33 through 36 in the appendix, where you can observe that we've seen a slight decrease in adult and child preventive services, but significant increase in maternal and child health, chronic conditions, and behavioral health HEDIS metrics. The majority of quality measures have trended upwards from measurement year 2018 to 2021. And one can also observe that we have seen an increase in the use of telehealth services to boost performance in applicable measures, mainly in behavioral health. Substance use and related behavioral health measures, we've seen some mixed results, and we're looking forward to continued improvements over time. I'm now going to turn the time over to Amanda Stamper, Anthem's Community Relations Director, who will discuss our member incentives, value-added benefits, and community engagement activities. Amanda?
Thank you, Leon. At Anthem, we are committed to educating and incentivizing our members to ensure they are taking the necessary actions to improve their overall health. Our Healthy Rewards program offers member incentives for engaging in health and wellness activities that are tailored to meet a variety of member needs. As you can see in the member scenarios on the chart here, members can earn a significant amount of money by completing certain activities such as checkups and vaccinations. For example, a pregnant or new mother can earn up to $375 for participating in services that will support better health for her and her baby. Members can also receive their incentives in the form of a MasterCard or a gift card from retailers or restaurants such as Walmart, Amazon, or Subway. The addition of the MasterCard that we've implemented was based on feedback from this MAC. In addition to our Healthy Rewards program, we also offer a suite of value-added benefits that enhance the way members can gain access to services that help them improve their health and items to make their day-to-day lives a little easier. We tie eligibility of these benefits back to tasks that help us serve our members, such as completing their first prenatal visit to receive 200 diapers, or filling out the HRA to receive $200 in gas cards, bus passes, or Uber cards. I would also like to point out that Anthem has moved to a more user-friendly platform for both our programs, while keeping the phone ordering an option for members without access to the internet. On this next slide, I'm going to talk about how Anthem is using innovative digital solutions to improve health equity in rural areas as part of our population health model. We offer digital solutions that reduce barriers and increase engagement for prediabetes, mental health, substance use disorders, and smoking and vaping cessation. We also offer Live Health Online to make visiting the doctor easy, right from the member's own home. Our community resource link also allows our members to find local resources that can offer assistance, such as food banks and homeless shelters. In working to address maternal health disparities, as you can see over here on the right, in Fayette and Jefferson counties, we have developed a doula pilot program in partnership with several community organizations that serve eligible pregnant women, not just Anthem members. Early outcomes show extremely positive results for African American women, and we're looking to expand this program into rural areas across the state. We recognize that to effectively address the social needs of members and communities to support whole person care, we need to be actively engaged in communities and meeting members where they are. And we have a number of associates dedicated to just that. As you can see it with the dots on the map here, they're spread all across the state and they all have different roles. Our community outreach specialists develop meaningful relationships with community-based organizations to grow and maintain our network of partners who can provide social supports. Our public health consultants provide healthcare outreach and education to communities, and our community engagement navigators work with members directly in their community to address SDOH barriers and connect members to benefits and community resources. On this next slide, you can see in the chart the variety of social needs our community engagement navigators meet for members. In fact, our CENs are the backbone of our empowerment program, addressing those SDOH issues that are critical in advancing health equity. Through our Housing Flex Fund, CENs can help with things like housing for our homeless members, buying essential move-in items, and preventing utility shutoffs. I would now like to shift from talking about social needs to a more traditional healthcare services. So I'm going to pass the time to our medical director, Dr. Brunner.
Thank you, Amanda. For those I have not met yet, I'm Daniel Brunner. By training, I'm an emergency physician and practiced for over 20 years in Northern Kentucky at St. Elizabeth Healthcare. Prior authorization is an important tool for managed care, as it is a call to action for care management and other teams that support our members through their care transitions. Anthem reviews our PA process quarterly. These reviews help us to monitor utilization patterns and can help us identify opportunities to streamline processes. Because of this process, in 2019, Anthem removed 82 codes from prior authorization after analysis showed these services were almost always authorized, placing an undue burden on providers and members. For the same reasons, we also removed targeted case management from prior authorization to decrease the administrative burden on our BH providers. The medical necessity criteria not being met is a leading driver for our PA denials. You can refer to slide 38 in the appendix to see the other top denial reasons over the last 3 years. One tool that could help lower the rate is our interactive care reviewer in the availability platform, which offers a streamlined and efficient way to request PAs. The ICR allows detailed text, photo images, and attachments to be submitted along with the request. The tool can also be used to make inquiries on previously submitted requests, regardless of how they were sent. PA requests can be made 24 hours a day, 7 days a week through ICR or by phone. This slide outlines our top 10 diagnoses in each of the past 3 years. Opioid dependence was the top diagnosis by dollars spent before the pandemic, and during the pandemic, substance-related diagnoses have risen to the first, second, and third highest amount by spend. On a claims count basis, opioid dependence was also the top diagnosis, but immunization and COVID were the next highest in 2021. In addition to working with the provider community and promoting MAT therapy, Anthem has also launched a digital program referred to as CHESS to help those in rural areas have access to community supports. This chart shows the PMPM pharmacy claims costs over time and reflects a 24% or just over $58 million increase in costs since July of 2021. The rate of growth slowed slightly in April, but pharmacy costs remain one of the major areas of concerns for Anthem. While we have multiple strategies to address ER diversion, and looking at ER visits, the most significant driver for lower ER usage for BH and physical health in 2020 was the pandemic. Skilled staffing and bed shortages contributed to the higher decline for behavioral health versus physical health in 2021. It's our belief that the increased use of telemedicine may have a lasting impact on lower ER and hospital rates because of the increase in access. Inpatient admissions dropped significantly in 2020 due to the pandemic. The decline has leveled off, but hospitalizations have yet to return to pre-pandemic levels. The higher decline for behavioral health versus physical health in 2021 is due to the pandemic, staffing shortages, fewer discharges, and longer lengths of stay due to the PA waiver impacting the continuum of care. The pandemic led to a more emergent mix of admissions, which led to more readmissions. Readmissions per 1,000 declined due to pandemic-related capacity constraints and the PA waiver. The PA waiver has led to a disruption in the continuity of care, which has contributed to fewer overall admissions, discharges, and therefore fewer members receiving treatment overall. The PA waiver has made care coordination and addressing SDOH needs more challenging. I'll now hand it back to Leon to finish our presentation.
Excellent. Thank you, Dan. So some of the questions asked by the MAC had to do with our typical operation systems. And so I'll quickly address them here. Claims denials, for instance, our top 10 denial reasons, or top 3 of the top 10 denial reasons are related to coordination of benefits with a primary carrier. So those, of course, don't really reflect a payment issue, but rather the assurance that the payment is being made appropriately by the primary insurer. The other top reasons for claims denials include procedure non-reimbursable and duplicate claim, both of which are primary duty of managed care firms to try and make sure that we eliminate some of those redundancies. With regard to audits, our Special Investigations Unit is charged with preventing fraud, waste, and abuse by proactively detecting instances using algorithms, investigations, and record reviews. Upon completion, each case is sent to DMS, where they too analyze the findings. In 2021, to make the records request process as efficient and less burdensome as possible, Anthem announced an enhanced medical claim attachment capability through the Availity platform. Most providers are taking good advantage of that. As provider practices improve connectivity to health information exchanges like KHI, it will lessen the administrative burden of record requests from the payers. The COVID pandemic has changed all of our lives, and as we as an industry have had to rise to meet the challenge of creating better awareness, access, and improved health literacy, we used a variety of methods to educate members and support distribution of the COVID vaccine. Anthem combined an extensive member education program with an extensive provider education program and incentive program to influence results. As of March 1st, 44.73% of our vaccine eligible members have been vaccinated. In closing, I want to thank you and your time and attention today, as well as your ongoing partnership. The key points that we've reviewed for you today include a profile of our membership, our efforts to improve access to high quality care, the ever increasing results to demonstrate quality, our efforts to increase member engagement, and some of the ways we're working to make things administratively simpler for providers so that you can focus on patients. I would also like to take this time to thank each of you for your respective tasks as you work to help improve care and care delivery of our Medicaid members here in the Commonwealth. If we have time for a few questions, I'm happy to take those now.
Does anybody have any questions?
I have one, Beth. Early in the presentation, you showed a slide about access to different kinds of providers, 30 minutes, 30 miles, so forth. There was an entry there and it said psychiatry. So my question is that inclusive of all behavioral health services? Or is that only access to psychiatrists?
Depending on the first slide, I believe was actually, now the one, okay, so psychiatry, 461
Right.
of which,
Right.
yes, so that is just psychiatry. That does not include all of the other behavioral health practices.
And could we get that figure from you?
Of course.
Does psychiatry include APRNs?
I think that is actually listed separately.
Okay. I'll also be interested in seeing the details.
Yeah, it would be helpful to get the psychiatrists and the APRNs who are the prescribers
Sure.
in a separate category, I think. Don't you think, Nina, from those who provide evaluation and therapy?
Yes, I do, because in our practice in much of the state, psychiatry and APRNs are interchangeable in terms of the functions they perform.
Excellent. And I'm pretty sure those are in the details of the report, which we've included as part of the attachment, but I will call that out and bring it specifically to your attention. So thank you for that.
Thank you very much.
It's our pleasure.
Lindsay Wallace had a question in the comments. Ms. Wallace, did you want to ask your question?
Yeah, I was just wondering, are geriatricians not a key provider type? Or do we have data on that at all? I just noticed in both the presentations from the MCOs, there wasn't really any discussion of geriatricians at all. And so I was just curious.
Let me double check on the report. I'm pretty sure we have that. Brian, are you by chance on and could familiar with the real details in the PSN 09 or PSN 05 reports? I tell you what, I'll take that back and we will make sure to get back with you. Of course, it is many of the Medicaid members are also Medicare eligible or aged, and so geriatricians would be something. Our average age of population is 31, but we do have many that would probably definitely need your services.
I think Dr.
Thank you.
Barbara. Garth, I saw something in the chat. Did you have a question?
Yes, I was just asking about the value-based payment program, if that included dental care.
We're in the process, Dr. Bobrowski, of considering some different things we can be doing to enhance that, but happy to be able to work with you and the dental TAC to be able to try and see. I know your concerns about the reimbursement rates are well understood and noted. And so being able to work with them, and I'd also like to see if we can find a way to do something about that, the no-show rates that you've described. That's, my heart was aching when I heard you talk about a young man who has missed 11 appointments. Those are so precious, and that time is so precious. We need to work on that together.
I agree, and I appreciate that comment. That I'd like to see that the the MCOs kind of work together here through this MAC, and just I know there's national policies out there, but sometimes the states can drive some of the thinking going forward, and you guys and gals can help us.
That's one of the benefits of managed care. We have some degrees of freedom that typical systems may not have, and we can do some creative pilot programs
Right.
to find out what's going to work.
Yeah. Appreciate that.
Dr. Borowski, this is Dan Brunner. Annual dental visits is part of our pay for quality pediatric measure in value-based care.
Okay.
I had a question about the map where you had the little dots showing where providers were. I noticed some of those were out of state. So are you reimbursing out of state providers for Kentucky residents?
Yes, we are. In fact, there are many instances where both providers and members are, these are just contiguous counties. By Blue Cross Blue Shield Association rules, we're only allowed to contract with contiguous counties in an effort to be able to increase access. And so you'll notice that most of those are in areas that, have another community just beyond. And we definitely reimburse those at the state reimbursement levels. So I appreciate the question.
Okay, thank you.
And Dr. Parton, the largest conglomerate in the Northern Kentucky area, that's Cincinnati Children's Hospital, which is a major referral hospital for the area and the country.
Thank you very much. And again, we've received a lot of information. So members of the MAC will look at these slides, and then at the next meeting, if we have any questions, we'll have a brief period of time where we can ask those questions. So thank you for coming today. We appreciate it.
It's our pleasure. Thank you for having us.
Okay, so anybody on the MAC have any new business they'd like to bring up? Okay, well, thank you, everybody. And we have managed to stay on time. So I appreciate all of the TAC members for brief. That's been very helpful today. And I know that you always have a lot more to say. And so I appreciate you limiting that today so we can get this other information out. I'll entertain a motion to adjourn.
So moved.
Second.
Did you have a question, Nina?
No.
Okay, sorry, your picture popped up. Okay.
She said something.
So moved to adjourn.
Yes, so moved. Thank you, everybody.
Thank you.
Thanks, everybody. Have a great afternoon.
Bye-bye.